This is our last chapter. It's chapter 10, and it's called Risk Management. This chapter, I'm not going to read every one of these, but it has to do with risk management and audits and what makes a good document as far as legally, and goes into the type of dental records that you should be having, especially if you're ever called to a court situation, and how to put together a risk management program. These are really, it is an important thing for an office to do, mainly for your own protection. These, having risk management programs set up in your office is a protection for you as the provider. So our primary goal as a hygienist is to provide care to patients, of course, promote prevention of oral disease, because we're all about prevention, and maintaining oral health, optimal oral health. But those are our goals, and in real life, we know that some unanticipated things can happen. This is also called the same thing as untoward. Untoward is a word that you should be familiar with, and it does mean, it means something that you wished hadn't happened has happened. So something bad has happened, and now you have to deal with it. So some untoward outcomes or unanticipated outcomes, you could be doing the very best and striving for our primary goal in maintaining the patient's health, and so you are doing SRP to hopefully rid of periodontal disease and calculus or whatever, and all of a sudden you break off a tip. So that would be an instrument tip. It would be something that was unanticipated. Now, actually, this is the example that the book is giving, and this is a true thing, but something like a tip breaking off is something that really should be anticipated, because you should be trying to prevent any harm to your patient, and any harm is making sure of your instruments are in good order before you put them in the mouth. So that would be the first thing I would tell you. But secondly, let's say that it wasn't like super thin instrument. We're to the point of looks like you could just blow on it and it would break. But there was just that much calculus, and pulling on it at with certain strength broke the tip off. Let's just say that for this chapter. Patient having an adverse reaction to local anesthetic. Now, your whole goal in giving the local anesthetic is to try to relieve the patient's pain. And so all of a sudden they have this adverse reaction to what you were trying to do good. So we need to try and anticipate things that could go wrong, and right that wrong so that the least amount of untoward things will happen. And if something does happen, we need to anticipate what could happen and have a backup plan already in place. Like if you break an instrument off, what do you have a magnetic perio retriever? So does your office, is there a way that you have cotton rolls and isolation equipment, products out there to quickly be able to isolate, because you're not supposed to let that patient swallow that broken tip for sure. We need to get it out. That way we know that it really is out. And if the patient does swallow it, then they're going to need to have an x-ray. If for some reason it was sharp enough to penetrate somewhere along the line of your esophagus to your rectum, if somewhere along the line it was a sharp edge somewhere, it could get embedded in any organ or, um, um, through that whole process. So it could be a really dangerous thing. So we want to have a risk management plan set up to where these things, we cut the number of our risks down. And that way we don't have to deal with very much. So why is this important? Basically of what we just talked about. General dental practice may not provide really complex oral surgery procedures because the clinicians have determined that extensive risk factors are associated with those procedures. So if you know that good infection control is not going on, that the instruments are rusted, that the dentist may use for some type of surgery, all of these things, everyone should have a little bit a hand in this in the office. It's hard for one person to take on all the different areas that you could be risk worthy. And so really it would be better if it was split up into certain things, in my opinion, that each hygienist was responsible for, 3 to 5 issues. One's responsible for the instruments, as far as making sure that they're safe, okay, etc. And you could go on to nitrous oxide tubing and on to parts of sterilization, etc. So the liability is too high sometimes, making the risk of actually having an SRP or surgery of some type, it's not worth the risk. And so we don't do them. Well, offices are there as a business, and as a business, they are supposed to make money to stay afloat and pay everyone's salary. So as long as if you have one of these risk management systems set up, it helps cut down on any of that happening. Still, there are accidents, things that can happen. You can have an instrument that was flawed in the making of it, maybe straight from the manufacturer. But but at least it didn't come because no one was paying attention that you had too thin of a tip, is what I'm saying. Eliminating high-risk procedures is not always possible or desirable. So that's why it would be really good to, as I say, to have a strategy. Risk management, it's a term that describes how a dental hygienist can anticipate potential unfavorable outcomes and have already implemented strategies to minimize their occurrence, which is what I've been saying. So management means that once a risk is identified, it's measured for the seriousness and the likelihood of its occurrence, like the seriousness of the potential outcome and the likelihood of its occurrence. Some people, and if it's something in the office that's really not a likelihood of occurrence, etc., then maybe you skip that, or you can even, to show that you didn't just forget something, I would maybe write it, put it in writing, write it down, and then I would put no seen risk or something like that after it. So a strategy then is created to handle that risk in such a way to minimize it, or in some cases, as it says, to eliminate it altogether. So it's defined risk management system of injury prevention. That would be a good way to define risk management. First, you have to identify if there's a risk, and the management strategy to prevent, minimize, or eliminate it. So prevention requires awareness and knowledge of the most frequent occurrences of negative incidences. So you need to have a familiarity with professional literature. So a lot of times these magazines that you will get after you graduate, a lot of them they come free. And if you want to look at it online, that's fine too, but they will keep you current. They'll have issues and they'll have a small article about instruments, and they have a small article about other things in our practice that you can just quickly keep up on. And there's no CE involved in it. It's just little tiny articles so that you can keep up. Incident reporting for a specific practice, and implement a quality improvement program. So risk reporting and quality improvement, I put them into columns. Risk reporting would be reporting of all incidents that are not that are happening that you don't like, and sometimes it comes from patient complaints, the hygienist or assistant or dentist complaints, and so you can always look at it that way. A good thing to have in your office, we have this in the clinic, and this is one of the reasons it's very important, is we have patient satisfaction sheets. And you can learn a lot if you start getting a lot of feedback that the instruments are, rough, or that you can even get some stuff from that, even other things even besides instruments. So when you do the reporting, you have identified a risk and you're going to do some reporting, you want to just report the facts. So you don't go off into this tirade of what you think could happen, possibly happen. At the very start of it, they don't want drama. They want facts. What are the facts? So that's what you simply and concisely record. Risk reporting can be retained in risk management portfolio. So if you have something happens like you would break off a tip with that patient, you would keep these have a whole different huge notebook, or hopefully smaller notebook, that's called risk management portfolio. You could just name it that. And you could have developed sheets and with columns and dates and what these are. And if everyone in the office would go do that and then see what you come up with at the end of the month. And then what you can do is, once you have that down, you might start seeing similarities in some of the equipment or something around the office, which would permit a quality improvement program or risk management program to evolve. So it permits tracking. So quality improvement, you're going to assess the patient care systematically, and that means that when everyone has training and you're all doing it in the same way, you have to all do your risk identification and management in the same way. Pick out the forms, make a form that you think is the best, and always start with one thing and type of a question and go down, and you want to do that 1, 2, 3. You can do it as the most important or the most recent risk identifiers, or the least, but it should be the same way for everybody. And it's an ongoing process. So it's not something that you're going to quit. It might be something that you look at month to month when you have an office meeting. So it's going to show a pattern, which is kind of what we've been talking about. And this is what's going to help you implement some kind of change. If you do something like that, the quality improvement program, there's usually 3 different dimensions of it. There's a structure, a process, and an outcome. So step 1, quality assessment. Step 2, design and implement strategies. And step 3, evaluate your strategies. So this is a continuous cyclical process of assessment, planning, implementation, and evaluation. So what this is part of our ADPIDE, because we have assessments, planning, implementation, evaluation. Okay, this is just not including diagnosis in the quality improvement. So 2 universally accepted strategies to minimize the risks to dental services are good documentation and careful communication. So if you can cut down a lot on your risks by having a good if everyone documents the same way. And if you're ever called to court, the office is looking very cohesive. And this could be something, as simple as your nomenclature, which is the verbiage that you're going to use. If everyone uses prophy and doesn't explain anything else that's in the prophy, but in your document notes, your SOAP notes, if you just put, patient received prophy today, and that's okay with your office to say that, you have to have defined somewhere that everyone, goes over in meetings, and it can be proven that you did exactly what a prophy means. And if you're ever called to court, if they call other people from your office and they say, well, what did prophy mean to you? Your patient maybe took you to court because you didn't give them the proper cleaning. And you say, it says right here, I gave them a prophy. And they're saying, you did not give fluoride, or you did not, your patient is saying that you didn't polish, or that you skip things. And so you can go to if they ask every single person in your office the same thing, and everybody says the same definition, what a prophy is, that would only help your case. And if you have it documented in some policy, from your office, that would help also. So these things, good documentation is key. And careful communication, communicating to your patient what you're doing and what you're not doing, and kind of factually documenting anything that would go on. So your patient record, it's a foundation for good documentation, ongoing assessments, treatment services, outcome, notations, patient contact. So any kind of, if you use the word like prophy, or you'll pick other words that you'll just, after a while, you'll get away from maybe the words and the verbiage that you were shown and learned in school and clinic, and your office may use, some other type of verbiage. It does, it's not that bad to do that, as long as it's documented somewhere in your office as to what everybody has the same understanding of what that means. Okay, if you're going to use something different than what you learn in school. So you want to always keep your documentation in a chronological order. It should be whatever needs to be signed and dated, then should be it. If it's written, or if it's electronic, then following the protocols of that. Personal data, health history, dental history, care and treatment records, cancellations, maybe put a date in there of when someone canceled. It might come in handy if someone ever gets kind of high-handed and horsey with you, or wants to take you to court. You can always say, this patient did not show up most of their appointments. It's documented right here. This patient doesn't comply. This patient has a a history of not, being honest or whatever. So notes from conversations, and you don't keep that in the patient. Well, let me say, you can put that in the patient record if you keep it factual. But as soon as you go off factual things and to things that, are personal thoughts that you have about what they probably meant or something, that's a no-no. So you can keep a different file if you choose to do that about patients, like in just a little like recipe box holder or whatever you want to do, notebook, if you want to for that. Sometimes what we do on the, which we'll get to in a little bit, on risk reduction, things that go wrong, you can put factually what they did, like broke off tip in patient's mouth and how you retrieved it, and how the patient, maybe you'd add a note the next day saying you followed up and called them and everything was fine. So that would show really good documentation on the provider's part. Would be really good. But things they should also be listed and dated in a risk portfolio or some place or notebook or binder that is just for writing up risk, what happened, and you could use your own words. Notes from conversations. Objective, professional, non-judgmental, and related to the treatment. It needs to stay that way, unbiased. So that's why if they're written in some book and they're written, and that's the way they used to have to do it before things got so, so many offices went ahead and got into technology and into computers. If you're writing something and that's one of the big reasons that you put a single line drawn through the incorrect information is so that it's ever in court, they can read that. And that's why you don't put 3 or 4 lines and kind of scribble through that or blacken it out or white it out, because it looks like you're concealing something. It looks like you're trying to hide something. And so that's why we do that. So the correction information then should be entered with a note of error and signed and dated. And I still do that in the patient record. If there was something that I find out later that was the next day or after the patient left that there was some kind of correction, I'll write an addendum. Because the way we do it in the school, once you sign off, an instructor signs off on that, we can't get back in anyway. So we would have to go back to that patient and that date and add in an addendum and say, the the blood pressure on, I would say addendum to note 12/2 of 19, semicolon, and say blood pressure was 160/80, not 140/80 or whatever, and then a dash and then my first and last name. So a lot of offices, they say, a lot of dentists that have at least worked with us in the not the ones that are there right now, but they don't like the word prophy. They say avoid abbreviations and just regular jargon that we use like prophy. And the reason is because it does mean different things to different people. Some people think the prophy is the scaling part if you talk to people, and some think the prophy part means that you've polished. If you've polished them, it's now become a prophy. All right, so that's why we like to, even though it takes a little longer, prophy is just too broad of a word if it comes back to know exactly the steps that you took so that you might be able to defend yourself against something. Consistency for all patients. Whatever your office decides to do, it should be consistent for every single patient. You need to abide by your state law regarding record keeping. If you move to another state if you start practicing in Kansas or Missouri and you move to a different state, you will need to abide by their state law regarding what they, certain things that you must have in the record keeping in your notes. Develop guidelines for the order of the notes. And that's why we have like templates. We make templates so that we have it in the right order all the time and it's consistent on every single person's computer. So you want to do a periodic review and make sure that the right information is being put in there. And that's a risk reduction that goes with documentation. And that's one of the couple reasons why we do chart audits, is because we need to do a periodic review. It's taught us a lot. We will do chart audits sometimes over the years and realize that not everybody is filling in certain spots, and then we need to go back and correct that. So your entries are clear, concise, legible if you're writing it, and permanent ink if you are writing it. Error corrected by additional entry, that's on the computer, that is your addendum. And the use of commonly understood acronyms. So don't start making abbreviations of words unless everybody understands, once again. So you could use, in your office somewhere, it should say, MAX means maxillary, LA means local anesthetic, and so on. So you want them to be acceptable, electronic record keeping, acceptable, same guidelines as for paper recording keeping. Most of those apply except for the signature part. And some offices even have a signature part on a iPad that they can give you. Not every office is going to have that quite yet. Electronic records are safeguarded from tamper. We need to make sure, and that's a risk reduction for your entire office. So it needs to be encrypted. Messages, and especially if they're going back and forth with x-rays and different patient information from one office to another. So other records in management, same with your radiographs, your models, photographs, everything needs to be safeguarded from someone else being able to get that information. So the patient does have legal rights to the documents. We've been over this before. Even, in 101 we touched on it, and in 102 we touched on it, but and touch on it again now, probably in other courses you will as well. So they have the legal rights, whether they've paid their bill or not, to obtain the original or a copy of the originals, and for either free or a very minimal cost. They are not supposed to be able to charge like, yes, we'll do that for you and you owe us $75, or something like that. That is not right, and it is not supposed to be being done. If it is, it should be for some minimal fee. For $5 we'll give you, $10 we'll give you, whatever. So practice may charge to duplicate records. That's what we're talking about, where the minimal fee would be. Confidentiality is a professional obligation with ethical and legal ramifications. So we'll learn in another, we've learned already actually that confidentiality, if the office manager is up in front laughing, with someone else about any personal issues of a patient that is in the back, they're actually committing a battery, a civil offense against that patient. Okay, so a lot of offices still do that amongst themselves, but that's the law. Okay. Key to a successful, safe, and satisfying practice is to minimize as much risk as possible. Patient relationships are built on communication. Be good communicators. It's essential to be a good communicator between the employer, colleague, and other healthcare providers. Success in a practice depends on delivery of what you're saying, your attitude, your tone and volume. If you're saying something in a sarcastic way, or the fact that they're questioning, I say this because I was temping one time a long time ago. I was subbing in for an office that needed someone, and there were only little thin partitions between 4 hygienist rooms. And I heard, so you could hear everything in every room. So I heard a hygienist 2 partitions down. She was say to her patient this, and her patient was obviously trying to decide whether they wanted to do SRP or not. And I heard the hygienist look at, turn to the patient and go, "Are you saying that you want to lose your teeth? Are you saying that? I mean, if you want to lose your teeth, then don't do this. But if you want to keep your teeth," I mean, in that kind of a tone of voice, I almost got up from my patient and went over. I was so angry at her attitude. So your tone and your volume can make a big difference in how a patient perceives what you're telling them. And you need to have an ability to be able to really listen to your patient. So some of the things I will just say before we go on where I see a big difference is something you could get used to saying to your patient is tell me about your home care. And they're going to go like, what? There's like, what do you do? What's your regimen? Do you brush in the morning, in the evening? Do you floss? Like, what do you do? And so let them tell you a little bit so that they know that you are interested in what they're doing, and don't just come on to them like with a lecture right off the beginning, right off the bat. So ask them what they're doing. They'll tell you, and it will help lead you into something, less threatening way of, for you to say, well, really, that's good. Well, let me show you this. This may help you a little bit in being able to brush. I'll give you a brush and kind of we'll take a lesson and show you how, and maybe that'll make it a little easier for you or whatever. So effective listening, concentrate on themes, listen with an open mind, summarize what they're saying in your own thoughts, and clarify positions and statements in your head prior to commenting on them. Written instruction. A written instruction like home care instruction reinforces your verbal instructions, because they're not going to remember every little thing that you said. No one does, in the office. They're already thinking about when is this going to be over, because they have to pick up one kid here, another kid here after school, and still make it home to fix dinner or whatever. So they are half thinking of that and half listening to what you're telling them. So if you do an SRP and you give them some verbal instructions on what to do when they go home, rinse with salt water and how long and everything, that's why it helps to say it, and then also give them that written post-op SRP instructions, so when they get home they have something else to go by. It needs to be clear, concise, accurate, short. So you are what you're telling them. Summarize in your own thoughts before you write it down, so it comes out cohesively. If you're going to write something, we have this printed and customized SRP post-op. That's one of the reasons we have it that way, so that you won't forget every little piece of it. And it also allows for questioning, and it allows them to question you about what you mean and you to question them. And that's really great communication, is what it's talking about. So we also need to really watch our nonverbal communication. It's critical in communications. It's a two-way form of communication. Both of the patient and you are going to give off nonverbal communication. And that's why, especially if we have these masks on and we go back and we have, shields on and hair things and everything, and all they see are our eyeballs. And you're giving them an injection, and they're looking up at you because there's kind of nowhere else to look. And they see your eyes and your eyebrows go up like really surprised. What do you think they're going to be thinking? What are they? They're doing something wrong to me. They've done something wrong. What have they done? So we have to really watch how we are looking at our nonverbal communication as well as our verbal. We also, we've touched on this also in several different classes, the cultural or generational sensitivity. So we need to be aware of the differences, remain open to increased understanding and communication. We need to, a lot of the older generation, sometimes we had a hygienist one time that was subbing in, and there was this, I don't know, she was about 80 and just, 5 foot tall and just darling and sweet person that was just coming in for regular cleanings. And the hygienist, she thought she looked so cute that the patient was laying down. The hygienist was sitting in her chair kind of at a 9 o'clock to this patient. And I walked by just when I saw her cup. She put both hands around the the sides of her head, and went, oh, almost as if she was a baby or a dog, and went kind of like, oh, you're so cute. Oh my gosh, the patient didn't say a thing. It's like we heard about it at the front desk where I was. I had a patient that had canceled, so she came out, and boy, she was fuming. She didn't say anything to the hygienist that was subbing, who treated her, but she said plenty to the rest of us. So you got to watch generational things and sensitivities, cultural sensitivities. Electronic forms of communication, email and other forms, they must be clear, concise, and accurate. Messages are more easily misunderstood. People slur their words. You've probably, or will, each of you will have a lot of time up at the front desk, and not probably during this COVID thing, but afterwards, and you need to have some experience up there, and not just to learn how to work that, but for things like this. Until you actually are in there and hear when you're the person behind that desk and have to listen to messages and call people back for appointments, you're going to see that some of the messages or that they leave on a voicemail or you can't even understand what they're saying, and they may not even be a different language. Okay, so we need to make sure that we are speaking to them more accurately and slowly, and enunciate. So documentation, once again, is factual. It's not biased. or personal, which is subjective. So individual risk management. This is for us. The individual risk management for each person at the office, and the hygienist list would be this. We need to maintain professional competency. We need, which is CEs and all of that, articles mainly that are written, because there's understanding CE requirements a few more down, and these would be decided together. We need to maintain our license, is showing that we're professionally competent, and which is the maintain credentials. We need to really understand and know and not go above our scope of practice or the things that we're licensed to do. Belong to the ADHA, hopefully, the state and local components. It does cost, it's expensive. It's like $250 or something or more a year to belong to the ADHA. I think you get a special student rate when the year you're graduating, possibly, don't quote me on that, but afterwards it's kind of expensive, but it can be really helpful. Update your CPR requirements, which most offices require you to do now, to update your CPR and get your card, and carry adequate liability insurance and understand the coverage. Not everybody, I can have liability insurance, and mine covers just lawsuits, possible lawsuits or something, where Dr. Thurlow had that, plus she got coverage that disability coverage is what I was trying to think of. And who knows, she was so young when she wound up with this rheumatoid arthritis in her hands, which made it really hard for her to continue practicing. And she smartly had disability insurance. So that, was an extra boost for her. I didn't get that because I thought I would be paying so many decades, and I still don't need it. I could go back to work tomorrow. Actually working that much. I do not have rheumatoid arthritis, but anyway, you have the option of getting that. So social media. Oh, one bad thing about the insurance. The office, we work under our dentist, and they have insurance on us. So you don't have to have insurance. Some states absolutely make it mandatory. Some states, their Dental Practice Act will, for that state, will tell you whether it's mandatory or not for the hygienist to have liability insurance. So mine wasn't. I haven't actually checked this year if they've changed anything, but it had not been mandatory for Kansas or Missouri, but I did get it anyway, because I don't know, they've raised it a little bit. It's up to like maybe $83, $85 for $2 million worth of coverage, but it's 80 something a year, not a month. So it's not super expensive. I'm sure if you added disability on there, it would be, of course, a little bit more. So social media guidelines for use. You need to review very carefully prior to posting on social media, and have a way to safeguard patient privacy and confidentiality. They have always said, do not friend or like a patient, except I have seen offices, actually right before I was leaving my office that I worked the most at, they were suggesting that you do friend patients. It was a way to communicate with them. But as a rule, they just legally, they will say, that's not a great thing to do. So you'll have to see what you think about it when you are out there in private practice. And you need to understand the rules and policies of your employers and institutions. You know, like we've said a million times, saying the touting ignorance of the law isn't going to cut it. They're just going to look at you as not as competent as they thought you might be, because if you were, you would know where to go to, and you would understand the rules of what's going on in the state laws around your career. So, being with that, that is the end of this chapter and the book, and there will not be, as I've said, a quiz over this chapter, but any questions on it will be rolled over into the final and would be on your final study guide. But these are really good things to put into practice and not forget about. And that